In this video, we're going to learn about those important hidden organisms, the kidneys. Here they are. You can be a pathology hero a different way today by learning about pathology of the kidney. In this video, we're going to learn about lots of different pathologies of the kidney. Infections, pyelonephritis. Tumors in adults and children. Those really painful kidney stones. And the mysterious glomeronephritis. Pyelonephritis is an infection of the kidney. The most common way to get pyelonephritis is through an ascending infection from the bladder. A urinary tract infection spreads up the ureter to infect the kidney. It gives a characteristic segmental pyelonephritis, as indicated on the right. Predisposing factors to this kind of infection are reflux up the ureters, lower urinary tract obstruction, perhaps by stones, diabetes, which compromises the immune system, and vascular disease. The other way to get bacterial pyelonephritis is much rarer. Sometimes blood-borne organisms can settle in the kidney, giving rise to the spotty type of pyelonephritis seen in the picture here. Let's think for a moment about those important ureters, the guardians of the kidney. They prevent reflux by having a sphincter. The sphincter is caused by the implantation angle of the ureter through the wall of the bladder. If this is quite acute and there's lots of muscle pressing on the end of the ureter, it'll form a good seal and there'll be no reflux. But if the ureter comes in almost at right angles, the seal is much poorer and reflux occurs of the urine up to the kidney. It also forms little pockets that are much more likely to get infected. The bugs involved are E. coli, typical urinary tract infection bugs. It's kids who are much more prone to reflux. They have a thinner bladder wall. They're diagnosed by urinary tract infections in children, which almost always get investigated for the possibility of reflux. We want to avoid chronic reflux because it can lead to scarring in the kidney in adults, and this leads to decreased renal function. Fortunately, ureters can be surgically reimplanted to give a much better angle through the bladder wall and cure the reflux. Sometimes the kidney gets chronically inflamed, chronic pyelonephritis. There are many reasons for this. A common one is vascular insufficiency. Some people, often due to hypertension, have poor perfusion of the kidney parenchyma. The little arterioles in the kidneys, they get smaller and smaller, and the kidney doesn't get enough blood. This can lead to scarring. And with the scarring comes lymphocytes and chronic pyelonephritis. The lymphocytes lead to increased tissue destruction, and that's replaced by fibrosis. And before you know it, you've got a shrunken, knobbly kidney that's just not doing its job because of chronic pyelonephritis. The things that lead to chronic pyelonephritis are diabetes, again through the vascular mechanism, along with hypertension, but also repeated infections. A key word in describing chronic pyelonephritis is thyroidization of the tubules. The picture of the bottom right shows tubules with pink stuff in them. That resembles the pink stuff in thyroid follicles. Hence we call it thyroidization. Another really important disease in the kidney, though much rarer, is renal papillary necrosis. Now, the papillae are those pointy bits at the end of the wedge-shaped sections of the kidney, and they can slough off and obstruct the ureter. What causes them to slough off? There's two basic things. One, they don't get enough blood, like in diabetes or in chronic pyelonephritis. And the other thing is analgesic nephropathy. So what is analgesic nephropathy? It's when people take too many non-steroidal anti-inflammatory drugs. And this again reduces the blood flow to these papillae and causes them to slough off. Mostly this doesn't happen these days because we know the danger of non-steroidals, and so are quite careful in the amount that we give people. You'll have noticed hypertension coming up quite a lot in this discussion of kidney disease. So what does hypertension do to the kidney? Mainly it affects the arterioles, these little blood vessels that come off the larger arteries and give most of the blood flow to this highly vascular and active organism. Macroscopically, the kidney becomes kind of flea-bitten as it develops numerous tiny scars in the cortex. It develops these scars because it's not getting enough blood. Microscopically, what we can see in the far right picture is the thickened wall of the arterioles, which reduces the lumen size, and hence we get a decreased blood flow. What we can see in the far right picture is what happens in hypertension in the arterioles. There's a thickening of the wall, often with concentric lamination, called onion skinning, and this reduces the luminal cross-section, which means much less blood flow. The other microscopic pictures show the effect of chronic inflammation, which comes into the areas of scarring, and then a picture of the glomerulus on the left-hand side shrinking down as it doesn't get enough blood. There's a complicated feedback loop around this, involving release of renin, which I know you've learnt about in your physiology. And the higher the blood pressure, the worse the scarring. So hypertension leads to chronic pyelonephritis and in time to renal failure. There are a group of diseases that cause cysts in the kidney. The most common of these is adult onset, autosomal dominantly inherited polycystic renal disease. It gives rise to kidneys like those illustrated on the right. And boy, are they giant kidneys. So the normal kidney is about, say, 11 centimeters in size, but these can get up to about this size as cysts accumulate. They accumulate in the tubules as they expand and get lots and lots of fluid in them, and they squeeze the rest of the kidney out of existence. There are lots and lots of kinds of adult and juvenile cystic disease. Your radiologist will help you work out what they are. In adults, a really important disease is renal cell carcinoma. We're discovering this more and more as what we call incidental omas. So patients these days have many more X-rays, CT scans, MRIs of the abdomen, which include the kidney. Often these show small renal cell carcinomas before they've become symptomatic. So previously, painless hematuria was a sign of renal cell carcinoma, and it still is. but these days many cancers are diagnosed before they become symptomatic. Renal cell carcinoma arises from the tubular epithelium, and it has a particular propensity for spreading into blood vessels, particularly into the renal vein, as illustrated at the bottom right here, where you can see it spreading down that vein and into the vena cava, some of it being known to spread up there and into the heart as a continuous tumour. The top picture shows the kidney with a tumour in it with typical appearances. It's a yellowish tumour with areas of necrosis in it. Wilms tumour is a very rare but important childhood tumour. It occurs only in the kidney and is due to embryonic appearing renal tissue. It's often discussed in pathology not because it's common, but because it shows important principles about tumours in children. It has a specifically associated translocation. It's associated with some whole body genetic abnormalities that carry this translocation. And it's a tumour that's made up not just of one cell line of differentiation, but many cell lines of differentiation, some showing mesenchyme, some showing primitive glomeruli, and some showing primitive tubules. That's because it arises from an embryonic type cell that then differentiates as it forms the tumour. Kidney stones. They're said to be as painful as giving birth. Most of them are formed of oxalate crystals. So people with a high uric acid in the blood form crystals with a mixture of uric and oxalate crystals. These then pass down the ureter, and this is when the trouble begins. Stones passing down the ureter are incredibly painful. Eventually they pass and the pain goes away. How to avoid them? Well, the first thing is to choose the right parents. You don't want to have a tendency to have high urate levels. Remember the gout? That has high urate levels, so people who get gout also have a risk of kidney stones, and this can be inherited as a metabolic variant. Dehydration also can cause kidney stones, as can a high protein diet. Calcium oxalate can also form kidney stones. They are really, really painful, but can be seen quite easily now on spiral CT. The ureteric dilation that accompanies them is characteristic, but we don't usually need investigations to diagnose kidney stones. They have a really characteristic clinical syndrome. A colicky pain that appears often at night and is, as I've said, very, very painful. We're going to conclude this video lecture by thinking briefly about glomerulonephritis. Now, the subject of glomerulonephritis is this big, but we're just going to think about it, yes, in simple terms. We're going to think about it in terms of the way that glomerulonephritis presents. It can present with nephrotic or nephritic syndrome. In nephrotic syndrome, there is massive proteinuria. This leads to a decrease in the main protein in the blood, albumin, so hence hypoalbuminemia, and it leads to edema because the decreased osmotic pressure in the blood means that more fluid leaks out into the tissues. The key idea in nephrotic syndrome is that there is a derangement in the walls of the capillaries in the glomerulus, which causes proteins to slip out of the blood into the urinary space and into the urine. In this diagram, we can see a normal glomerulus on the left. This has got a blood vessel lined by endothelial cells, a white-looking basement membrane, and the cells that look a bit like Pac-Men. They've got a nucleus, but then all these little pseudopods that reach down and touch the basement membrane. They're called foot processes. In a lot of nephrotic processes, the foot processes are lost, and the Pac-Men develop this little smooth outline. This means that the barrier that prevents proteins being lost into the urine is damaged. There are 4 diseases that commonly cause nephrotic syndrome. Here they are: minimal change, which commonly affects children; membranous GN, which commonly affects adults; membranoproliferative GN, which is really uncommon; and focal segmental glomerulosclerosis, which is one of the most commonest kinds of nephrotic syndrome in adults, and one of the most important diseases that can lead to chronic renal failure from nephrotic syndrome. What do you have to remember from all these diseases? Well, I quite often remember MMMF for all the diseases. But most importantly, remember minimal change in children and membranous and focal segmental glomerulosclerosis in adults. The other syndrome that people present with in glomerulonephritis is nephritic syndrome. Hematuria, blood in the urine; oliguria, which means they don't pee much; some protein; and hypertension. But the first 2 are what really distinguish it from nephrotic syndrome. In nephritic syndrome, the cells in the glomeruli proliferate. These can be cells intrinsic to the glomerulus, and inflammatory cells can come in too. All the inflammatory cells, they damage the capillary walls, they punch holes in them, allowing the red cells, these big chunky red cells, to leak out, giving rise to the hematuria. It's really hard to pump blood through a glomerulus when it is stuffed full of cells and the capillaries are closing up. So the glomerular filtration rate goes down, leading to oliguria. And the hypertension, the blood pressure, increases as the kidney tries to compensate for the decreased amount of blood trying to get in there. So here are some common diseases that cause nephritic syndrome. Acute infectious, otherwise known as post-strep glomerulonephritis; IgA nephropathy; and some hereditary nephritis, which is due to really thin basement membranes. Again, I just remember it by the initials HAI. Postinfectious glomerulonephritis is an important disease in children. It occurs after group A strep infection, just like rheumatic fever, but the pathogenesis is completely different. In post-infectious GN, the body makes antibodies to the strep. Now the antigens from the strep, they combine with the antibodies, forming these big lumps of protein which get stuck in the glomerulus. These irritate the glomerulus and make the cells proliferate and attract lots of inflammatory cells as the complement system is activated. Sometimes people get rapidly progressive glomerulonephritis. Many of the things that cause nephritic syndrome can also cause rapidly progressive glomerulonephritis. In this condition, the kidney function deteriorates over a couple of weeks, normal to no kidney function in a couple of weeks. It's often associated with immune complex deposition, such as in IgA nephropathy or post-streptococcal glomerulonephritis. It can also be caused by vasculitis, ANCA-related vasculitis. That's why we often test for ANCA when we're looking at people who have rapidly progressive glomerulonephritis. That brings us to the end of our consideration of all the pathologies that can affect the kidney, and they are really wide-ranging. We thought about acute and chronic pyelonephritis, with chronic pyelonephritis arising from scarring with hypertension. We thought about tumours that arise in adults and in children, and we thought about those really, really painful kidney stones. Then we tried to simplify glomerulonephritis into just two categories, nephrotic and nephritic syndrome, with rapidly progressive glomerulonephritis being caused by the things that cause nephritic syndrome, but in a really bad way. If you think of renal pathology in this structure, then you can overcome the fear of kidneys, the fear that the pathology is really complicated. Just take it one step at a time and you can be a pathology superhero.